So this is our final lecture, and today we're going to be talking about two different topics, schizophrenia and eating disorders. And compared to some of our other topics, this is going to be a little bit shorter because we don't have a lot of great psychological interventions for either of these yet, but I'll kind of discuss what's being done and some of the evidence for that. So in terms of schizophrenia, that probably approximately 1% of the population will have schizophrenia at some point in their lives. It usually develops late in adolescence and then in their early 20s. And so especially with males, we'll see the onset somewhere between 18 and 22, so kind of in that transition from high school to college, and usually a later onset for females compared to males. So with females, you're seeing it kind of in the mid to late 20s. The course of schizophrenia is usually chronic, so once people receive a diagnosis of schizophrenia, they usually have this disorder, which can wax and wane for the rest of their lives. Currently, the first and foremost treatment for schizophrenia is a biological treatment because I think most of the evidence suggests that schizophrenia really is a biologically based disorder. The genetic evidence suggests that it runs in families. We've done a lot of, brain scans. They've done, neurotransmitter stuff, and we do know that there's a biological component to it. There are different classes of medications. There are low potency and high potency. The low potency are the thorazine and the Mellaril, so those are kind of some of the older school ones. High potency is Haldol, which is more effective at reducing symptoms, but it's also more likely to cause extrapyramidal side effects. So that's kind of like what you've maybe heard of as the Haldol shuffle, where people walk kind of, dragging their feet. They also have the tongues that stick out of their mouths. Those of you who watch the terrorist show, I always want to call it Homefront, but it's with Carrie. Forgive me, I have dysnomia. I'm very poor at remembering names. But it's the show that's been very popular lately. Anyway, once she was medicated, you saw her in the psychiatric facility sticking out her tongue. That's an extrapyramidal side effect. Homeland, I believe, is the show. Forgive me. The newer ones are the atypicals, like Clozaril, Risperidol, and they are risperidone. They have fewer motor side effects, and so you're not seeing these extrapyramidal side effects, and they're very effective at reducing the positive symptoms of schizophrenia. None of these medications are so good at reducing the negative effects. And as with everything, there are limitations of medication. They're a treatment and not a cure, and so they help, get a person stabilized, but they don't get rid of the schizophrenia. That people will always have schizophrenia. About 55% of people will relapse, meaning that they will return their symptoms if they go off their medications. The meds, as I mentioned, are better at reducing the positive symptoms, but are less effective for those with negative symptoms. About 10% of people are not helped at all by meds. There are side effects even with the newer medications, such as weight gain, lethargy, increased levels of sleepiness, and about 80% of people, whether they're on medications, if they're on medications, will relapse after about 5 years. So that's something that's really important to know, and when you're working with clients with schizophrenia, to understand that that's kind of the course of the disorder. There will be waxing and waning in terms of the symptom presentation, and that there'll be different levels of effectiveness to the medications, and you'll often see that people will change medications frequently because one stops working. So some of the side effects of medication, these are important as a psychologist for you to know about if you're working with this population, is that your patients may be experiencing them, and you want to know what's realistic and what might be, some kind of a somatosensory hallucination, for example. But some of the things that you may see are dry mouth, sedation, blurred vision, constipation, weight gain, the extrapyramidal side effects like slow, awkward motor movement, activities, or tremors. The serious things are the tardive dyskinesia, where show the involuntary movements of the lips, mouth, tongue, and face. These are very hard to reverse once you get them, and so about 20% of people will get these, especially with some of the longer antipsychotic medications, and especially people have used them for longer periods of time. So you have to keep in mind that your clients may be dealing with some of these issues, and they're difficult to deal with. I mean, who of us would like to have involuntary lip movements or be, having difficulty with our bowel movements, etc. And so these are very realistic concerns that are associated with the long-term use of these medications, and so you have to be empathetic and help them overcome some of these issues whenever possible. So in schizophrenia, CBT is kind of an adjunctive treatment which aims to increase an individual's understanding of psychotic disorders, develop coping strategies for persistent symptoms, and foster self-belief and motivate clients to regulate their own behavior. So we are not seeking to cure schizophrenia with CBT, but what we're helping them do is to maintain themselves in the best possible state that they can, so they can live as much, a normal life as possible for them. And much of this is, associated with medication maintenance. So the treatment goals of CBT, using again the techniques that we've already discussed, are to reduce the distress and disability caused by the symptoms of schizophrenia. So for example, if they have paranoid delusions, to help them do some reality testing, cognitive distortions, etc. Pros and cons of believing certain things. And oftentimes with schizophrenia, some of these delusions are going to be very strongly entrenched. So even if you can get them to doubt it a little bit so that they don't become kind of overwhelming for them, they can improve the quality of their lives. You want to improve understanding and self-management. So understanding of their disorder. Many times people with schizophrenia don't have insight into their own mental illness, and so helping them acknowledge that they have this illness and understanding the ramifications of it on their lives, and that medication is an important part of maintaining a good quality of life, and helping them manage themselves in terms of minimizing stress and preventing relapse as much as possible. You also want to improve mood and self-esteem, because oftentimes when people have schizophrenia, depression goes along with that. You'll often see people with schizoaffective diagnoses, because when people have moments of lucidity, there's often the realization of what has my life become as a result of this disorder, and people become depressed. So it's not an easy disorder to have, but again, on medication and with help, people can live relatively good quality lives. You want to keep them as active a participant in treatment as possible. So in terms of coping strategies, you're encouraged to question their thinking. So look by perhaps looking at rational alternatives to paranoid ideation. And I've seen Beck do this with patients with schizophrenia. We once had an individual who was living with his mother, and she couldn't leave him at home alone during the day because he wouldn't cook meals for himself because he was convinced that the food was poisonous. So through, what was actually months of therapy, he was able to challenge that belief, and he put some contingencies in place so that he had specific things that he could use that he believed were no longer poisonous, and he could make himself a sandwich so that his mother could leave him at home during the day and go to work. You also want to teach them perhaps some distraction techniques so that they don't necessarily pay attention so much to hallucinations or just delusions. You also want to have goals to overcome hopelessness, and so you want to give them some short-term goals that are realistic and that they can work towards despite their disability. And so you want to guard against unrealistic concerns, because that's part of the disorder. Oftentimes people have very unrealistic goals for their future, but something like signing up for a course at a community college and taking that course might be a very realistic kind of goal, and give them some meaning to their life, or finding some sort of employment or things like that. Modification of delusional beliefs, which we've already talked about, and then modifying dysfunctional assumptions. So just by using Socratic questioning, question some of these entrenched beliefs that the individual has that are part of their disorder, and also the fact that they may have been told they have certain limitations because of their disorder. And so you want to challenge those with Socratic questioning, because in many cases people with schizophrenia can maintain jobs, and working with them to help support them through this process. So you want to, in terms of the cognitive therapy, you want to identify, understand, and analyze key cognitions such as these voices are uncontrollable, my illness is uncontrollable, the medication is pointless, schizophrenia means I have a lifetime of illness ahead, and all this mental torture is coming from others and not me. And so you would kind of work on doing basically a diary card. Might do pros and cons, might do a variety of different techniques. You also want to reduce safety behaviors, which are strategies that are used by the individual, like avoidance. But in other words, but instead actually seek to, prevent them from confronting some of their delusional beliefs. So if they feel like people are using x-rays to get through their windows, and then they put, tinfoil all over their windows, they are then protecting themselves from being exposed to the x-rays. So if we were having them actually be exposed to these x-rays by not having tinfoil on their windows and nothing happened, this would somewhat challenge their belief. It doesn't necessarily always work in a logical way like this with patients with schizophrenia, and they may come up with some other delusional explanation for it. But again, slowly you're chipping away at this. And therapy with patients with schizophrenia, it's not like a 12-session endeavor. This is, you may have very minimal gains after working with an individual, for a year, but minimal gains might improve quality of life, like having this guy being able to make his sandwich, which took months of treatment, improved his quality of life, and that he was able to be left by himself at home with the mother, and the mother could go to work, and so their financial situation was improved. You want to engender self-control and empowerment whenever possible, because oftentimes when somebody gets involved with the system, they lose a lot of that, so you want to give them power and control over certain decisions in your life, which improves their mood. And you want to give them, the opportunity to find out there are some things in their life that they can do to help. And not everything about their disorder is uncontrollable. You also want to focus on social and family contacts in terms of minimizing the stress and providing a supportive environment. So in control trials, CBT has been shown to have some effect in schizophrenia, even in people who previously did not respond to medications, and there are no physical side effects, and it's obviously a useful treatment alongside medication therapy. And it might be particularly useful for people who don't comply with their medication regime, or for people for whom drugs are not effective. And I think it's a very useful adjunctive treatment. A lot of work in terms of working with individuals with schizophrenia is done in family treatment, where families do exist. There's always that theory of the schizophrenic mother who causes the schizophrenia in her child, which we obviously know is fake and which is untrue and very harmful. However, we do know that patients with schizophrenia tend to have relapses in stressful situations, and oftentimes it's very difficult for a family to understand schizophrenia, the behavior of the individual with schizophrenia, and how that affects the family dynamic. And so family therapy involves factual education about the disease, about medications, the side effects of these medications, helping the family identify warning signs of a relapse so that they can make sure they can get them to the psychiatrist or hospitalized when necessary. We want to decrease expressed emotion. Expressed emotion is kind of the anger and a lot of yelling, because we know that leads to relapse. And we want to increase support for the patient whenever possible. You want to reduce the emotional stress and burden on relatives, because we know that caring for somebody in general is very stressful, and especially somebody with a mental illness, because people don't usually understand, and the person is very unpredictable. And there's a lot of blame on the person. If somebody has cancer, you can't really blame the person, but with mental illness, we tend to blame the person that they somehow caused this on themselves. So you want to help the relatives with their own ability to anticipate and solve problems for the individual, and reduce their anger and guilt by improving communication and problem-solving skills. So family therapy has been found to reduce relapse more than being on meds alone. Another thing that we can use is skills training. Also skills training, which involves life skills, social skills, and vocational skills. I don't know why this is doing this, so forgive me, but it's an interesting show. So you can do this in group or individual in terms of managing money, organizing and running a home, domestic skills, and personal self-care. Because of the onset of the illness being so young, many times these skills are not developed, or even if they are developed, people through the course of their illness lose these skills, so it's often good to teach individuals who have schizophrenia. Some of these techniques can be very helpful. And it's distinct but often paired with social skills training. And so it can either be done by a healthcare professional or nurses or occupational therapists. Social skills training are strategies aimed at enhancing social performance and reducing distress and difficulties experienced by people with schizophrenia. So oftentimes, they lose their friends that they had prior to the onset of schizophrenia, and it's often hard to make new friends, especially friends who don't have severe or persistent mental illness. And so you want to build up those skills. So you have to assess where the person is, the severity of their disorder. Some people completely retain their social skills, other people do not. And so you may have to do things like modeling, role play, and social reinforcement. That is Zachary, who is very unhappy that he only has 2 popsicles instead of 3. Vocational skills involve kind of pre-vocational training. Sorry, baby emergency. So pre-vocational training is that which the person is supported in some form of sheltered work before entering the real work employment. And so many times a lot of day programs have some sort of sheltered employment whereby, you know, there are different expectations and people have the ability to learn in an environment that is supportive, and they get paid kind of a minimum wage while they learn. And supported employment attempts to help people in real world employment, so they're actually maintaining competitive jobs, but they have individuals who are helping them and working with them. Usually this is known to the employer. Sometimes it could be behind the scenes where the employer doesn't know if the person doesn't want to reveal that they'd have a persistent mental illness. So just in terms of outcome, so this is the outcome is the percentage of individuals with a major relapse after 2 years. So people who just took medication and support or education, over 60% relapse. People who took drugs and medication, say drugs would mean medication here, and social skills training, there's a 35% relapse rate. And drugs and family stress management, you're looking at closer to 40%. So you can see that doing these types of things really impacts the number of people that are having serious relapse. So it's definitely well worth it because you're improving quality of life for the individual and their families. Cognitive remediation is actually a kind of a cool thing. Those of you who work with people with traumatic brain injuries may have already done this, but this is basically going on the assumption that people with schizophrenia have brain deficits, and then retraining some of those areas of the brain can help them with their everyday functioning. It's kind of like those of you who do like Sudoku and those kinds of word mind puzzles in order to keep your mind active is kind of the same theory. So it's a kind of intensive therapy that can help people with schizophrenia cope better with everyday life. It aims to help the patients improve their cognitive deficits, such as difficulty remembering things, poor concentration, or low attention span. And people may have problems making plans or making decisions, correcting mistakes, or coming up with new alternatives. And so it's just part of the illness. And so the hypothesis is that by learning these types of techniques and using these types of strategies, some of these deficits can be overcome or at least minimized. So just to give you an example, I worked in a cognitive remediation program when I was an intern at a psychiatric hospital, and it would involve things like using computer-based tasks to improve memory, using games such as Hangman, doing some stuff like with ADLs, like, you know, you're going to a grocery store, this is how much money you have, how much change do you get back, so kind of, you know, that here and there, because oftentimes, especially for institutionalized individuals, a lot of those skills, you know, we're not utilized on a daily basis, and we know the brain is a muscle like anything else, and if we're not using it, you know, it kind of goes to mush. So there is mounting evidence that improving patients' ability to learn, remember, and pay attention allows them to better cope with ongoing positive symptoms and lead more independent lives. As I mentioned, it can be done using computer games. Currently, the research doesn't show clinically relevant effects. However, they're still working on it. Those of you who are looking for internships, this is part of the New York State psychological, the Psych Center, the New York State Psych Center. It's the campus in Rockland. They do a lot of the work, the Nathan Klein Center. Again, my dysnomia, forgive me. I need to do some brain exercises, I think, since giving birth to 3 children in 5 years, and lack of sleep that went along with that. I've lost many, many brain cells that I'm working to recover, but I still am lacking, so you'll forgive me. Assertive community treatment is otherwise known as ACT. This is where patients are diverted to the care of a community-based multidisciplinary team. So these are patients who are identified as high service utilizers, so they're frequently in and out of emergency departments and inpatient hospitalizations. And it's been determined that it would be more cost beneficial to put them in a more kind of one-on-one community-based service of care. So they're assigned a team, they have low caseloads, and then members of the team carry very small caseloads, so we're looking at kind of, you know, 4 to 7 cases per individual, which they see frequently in their own homes with 24-hour coverage. So, you know, instead of the individual going out to seek services, which we know doesn't work necessarily that well with people with persistent mental illness, these individuals, these caseworkers, will actually go to their house. And there's a full range of clientele they serve. It's not just individuals with schizophrenia, but it's people who generally have mental illness and who are high treatment utilizers, and they're often given subsidized apartments. They can participate in day programming. There's a whole host of services offered to them. Even medical care comes right to their doorstep, and they found this to be extremely effective in maintaining people in the community and decreasing service utilization. So it's a very effective technique. A randomized controlled trial of assertive community therapy found that people using ACT were more likely to remain in contact with services and less likely to be admitted to hospital than those in standard care. They found that there was a 50% decrease in time spent in the hospital, which is a very significant benefit, both in terms of cost savings, but more importantly in terms of the quality of life of that individual. So as you can see, just to summarize, while we don't have cures for working with patients with schizophrenia just yet as psychologists, many of the things that we can do can significantly improve the course and quality of the life for individuals with schizophrenia. So I think it's well worth it that our services are very beneficial and can make a significant difference above and beyond just taking medication. So now shifting to eating disorders. This is a very challenging, especially when we talk about anorexia, a host of disorders to treat. The positive symptoms like obesity, where people are overeating, or binge eating disorder, are easier to treat using our standard psychological techniques. Anorexia, for a host of reasons, is very treatment resistant, and there haven't been a lot of evidence-based treatments that have shown significant efficacy in working with individuals with anorexia. So the first disorder we're going to talk about is obesity, and though it's not a DSM disorder, it's obviously a public health concern. So the overall rate of obesity is 34.8% in the US, and the rates have risen significantly and they continue to grow. The rates for men and women surprisingly do not differ, as they do with many other things. And generally the rates of obesity increase with age up to the age of 64 and then decline. They're significantly higher among Black and Hispanic females than other individuals in the population. So one of the reasons above and beyond kind of the concerns of obesity as a psychological issue are the medical complications that go along with obesity, because there's increased risk for heart disease and stroke, certain forms of cancer, and diabetes. And these are very serious concerns, and while, as we're young, we often don't think about these things, you significantly decrease your life expectancy by, sometimes 20, 30 years because of heart disease and stroke. And diabetes, I've seen, working in an old age retirement home, I've seen people, in their 60s losing limbs, having, knee, hip replacement because there's so much wear and tear on their joints. Obesity also contributes to elevated cholesterol, hypertension, and physical inactivity. So cognitive behavioral treatments for obesity again follow very similar models to some of the other disorders that we talk about in terms of self-monitoring. So you want to know what situations people are eating, looking at the antecedents, the consequences, the stimulus control. So are there situations like specific cues that are making people eat, and therefore we can eliminate those cues. We want to set realistic goals. We want to reinforce gains. We want to educate people about the consequences of obesity. We're not talking about people who, are pleasantly plump and, it looks nice on them. Like, we're not saying that everybody needs to be bone thin, but, to be medically, physically obese has many, medical outcomes. And they actually now insurance companies actually pay for gastric bypass surgery now because it's cheaper for them to do that than all the consequences of having the patient be overweight. And do cognitive restructuring about beliefs about eating, nutritional education, because in some cases it's just, people not understanding what kind of foods they should and shouldn't eat. Working on exercising and preventing, relapse prevention. And again, you want to talk about this similar to when we discuss substance use as a journey or a process, and that, we don't want to abstain necessarily, but kind of eating in moderation, and that should always be the key. You don't want to give up food groups altogether. For example, if people like sweets and they are obese, it doesn't mean they can never eat sweets again, but they can't eat a lot. They have to eat, maybe a few bites, enough to just get the taste. So There's a lot of limitations in terms of research on eating disorders because we don't have our studies last long enough for patients to reach their goal weight. Because oftentimes we get funding for 6 months, for a few years, and in many cases, if you're thinking people need to lose on average 1 to 2 pounds a week, if they need to lose hundreds of pounds, this can take months or years. There are oftentimes inadequate comparison groups and inadequate follow-up as well. So some of the things we know about improving long-term weight loss includes better screening, longer programs, incentives for increasing adherence, so we can, in our society, increase rewards for people to maintain weight loss, have social support, treatment matching, relapse prevention strategies, and integration of non-behavioral treatments such as mindfulness and things like that. People have introduced things such as mindful eating, so focusing on the here and now. Things as simple as decreasing plate size, because part of how much we eat is the perception of how much we eat. We're taught to eat what's served to us, but now what's being served to us are oftentimes 3 and 4 times what we should be eating, the recommended serving sizes, so understanding what a serving size is. So moving on to anorexia nervosa, there are 2 types, the restricting and the binge eating purging type. The restricting type is what we're more familiar with. That person doesn't regularly engage in binging or purging, but they do restrict their intake of food, so they're eating very few calories a day, if anything at all. Oftentimes they'll drink water, coffee, and maybe eat things such as carrots. The binging purging type can be sometimes mistaken for bulimia, but these individuals tend to always be underweight, as people with bulimia tend to be average to above average weight. And they're still restricting, but if they do engage in some kind of a binge where they actually do consume food, they'll engage in purging behavior such as self-induced vomiting, misuse of laxatives, diuretics, or enemas. I don't know if you guys ever watched Beverly Hills 90210, but Kelly Taylor, the character played by Jen Garth, is a good example of a binging, purging type of anorexic, where she would, exercise for hours on end after eating any kind of food, and so to counteract any food that was going in. Anorexia is the 3rd most common chronic illness in adolescent women. It's estimated to occur in 0.5 to 3% of all teenagers. We're seeing an increase now in the number of males as well, because there's increased pressure in the male community to look a certain way. Also, in the homosexual community, the ideal body image is generally thinner, so we're seeing increases in anorexia in the gay community as well. It usually first occurs in adolescence, with peaks around 13 to 14 years of age, and then again at 17 to 18 years of age. Over the past 40 years, the incidence has been steady in teenagers, but it's increased 3-fold in young adult women. And a lot of people think that has a lot to do with the media and the perception of women in the media. I talked about this in one of my other classes, but as a woman who has given birth recently 3 times, you look in the media and People magazine and stuff, and they highlight the movie stars who gave birth 2 weeks ago and are now back in their bikini, in their bikinis, and so they're making this seem like what the average woman needs to be like, and there's a lot of pressure. The same thing goes, people are retouching magazine covers, and everybody, we don't have a realistic image of what a real woman looks like. The average woman in America is actually a size 12, but that's not what the magazines are depicting. They're depicting something that's unrealistic for many people to obtain. So in terms of treatment, the first step in the treatment of anorexia is to aid the client adapt to a more standardized eating pattern. And this often, depending on the course of the disease, is usually done inpatient. And sometimes this is done via force feeding or tube feeding, depending on the client. Some clients will refuse to ingest food, and so they have to be hooked up to, a tube and fed intravenously. A dietitian may intervene at this point to assist the affected person to adopt more healthy eating behaviors, and the goal is to help the client begin to adopt more normal eating patterns. Now this is very hard, because this is like the greatest fear. What I found with patients with anorexia is they don't respond, especially initially, very well to cognitive therapy, because as a person goes into starvation mode, your brain isn't working in a logical manner anymore, and it's kind of like when people are just depressed, they only can focus on the negative. People who are anorexic are so food focused, and everything revolves around food, that they really can't see anything outside and beyond that. So it's only as they start to gain weight, usually very much against their will and much to their chagrin, that they're able to kind of engage in psychotherapy, and so they may have to be inpatient and gaining weight for a while. So this is often done against a person's will, and usually because they're underage, the parents can force this upon them as they're inpatient. So the goals of the treatment are to treat the medical complications that may have arisen. I mean, people can die from anorexia because of metabolite imbalances, return to normal eating patterns. What they find is that people with anorexia never quite return to normal eating patterns, but they do eat. And so while they'll, be probably thin and monitoring their food for the rest of their lives, they will maintain, a sustainable body weight. Provide guidance on nutrition and exercise, although oftentimes people are hyper aware of these issues, and they're just very distorted. And so you try to work on the distorted beliefs with CBT, although I feel like it's very challenging, and the person has to be ready to work on that. In the initial stages of treatment, people are not there yet, and they're not ready to make the changes. You want to educate the family about the disorder and help them in terms of providing support to their afflicted family member. And you also want to enhance self-esteem. So you want them to be more self-monitoring in terms of their eating and binging and purging and lack of eating behaviors, although these individuals are often very hyper-focused anyway, and many of them already do keep these types of food diaries and journals. Right now there is no conclusive evidence to support the efficacy of CBT, but in contrast, there's not a lot of evidence for anything else. So aside from strapping the person down and force feeding them, you do the best that you can in trying to kind of heal the individual and working through it. So CBT involves educating about the disorder, talking about things such as weight, calorie intake, changing health status, targeting the distorted thoughts, feelings, emotions, and you want to replace negative thoughts with positive ones, problem solving, alternate coping strategies. So again, the usual compilation of things that we do in CBT. In a more behavioral focused way, we find that people who use behavior therapy have increases in weight, eating habits, and body image, and these results remain for 7 years when the follow-up. And most of the patients had improved significantly in that 7 years. IPT that we talked about, the interpersonal theory, actually may work better than CBT because it's more relationally focused and talking about losses and changes and stuff like that. And so a lot of the self-image stuff can be conceptualized using IPT. It's still not shown that this is necessarily the most effective strategy yet, but it might be something that you would consider if you were working with somebody with anorexia. Bulimia nervosa is when people consume large amounts of food in a small amount of time, generally less than 2 hours. It's probably before your time, but I remember this made-for-TV movie with Meredith Baxter Birney, who was the mom on Family Ties, which also may be before your time, so I'm dating myself. But she had bulimia, and I remember her going into the fridge and just shoveling food in her mouth, and just taking cake and shoveling it in. And while that might be an extreme, it is not. It's more than kind of having an entire bag of chips or an entire bag of M&Ms or eating a full pizza or half a cake, which we all do at time to time. But this is really kind of eating very quickly in a small amount of time and having that feeling of being out of control. The prevalence again ranges from 2.8 to 5.5% of the population. CBT is actually relatively effective for bulimia. Again, because it's more of a positive behavior, we can decrease its frequency. So we want to monitor the episodes of binging and purging so that we know what sets the person off, because their episodes of binging and purging are often are emotionally related. It's not necessarily related to food. So you want to then expose them to those situations and prevent them from engaging in the binging and purging. You also want to do any kind of stimulus control or environmental change, so things that trigger the individual, making sure that food is not in the house. binging food, that is. You want to teach them specific coping strategies to deal with those emotional situations, cognitive restructuring, counsel them on dietary issues. A lot of people are not aware, and this is why many times people with bulimia are actually overweight, that even by binging and purging soon afterwards, they're still consuming a significant amount of those calories that the body can absorb. So that's why oftentimes, even though they're doing this, they're not necessarily losing weight. After about 12 months of CBT, 29% had recovered, 48% remitted, but there was a high attrition rate, although you can see that the results are relatively significant. So moderators of treatment outcome, people with lower body weight or BMI have a harder time, people with low self-esteem have a harder time, people who binge more frequently have a harder time, and those who have more personality issues also have a harder time in terms of better outcome. Binge eating disorder, similar to anorexia nervosa, is when you have the binges but you don't have the purging. So these individuals are generally overweight when you see them, but they have the same binging type behaviors. They do it at least twice a week for a period of 6 months. And it also causes them marked distress. So the components of CBT for binge eating disorder involve, the rationale for the treatment, monitoring when these binges occur, altering patients' meal consumptions to make them less vulnerable, because sometimes when people are hungry they tend to purge, and then doing relapse prevention. A lot of it can be, similar to DBT, using chain analysis or binge eating behavior or binge episodes, diary cards where you're tracking mood and how that relates to the binges, and then you assign homework in between sessions.